All right, so we left off talking about some social problems pertaining to healthcare in the United States, specifically looking at the amount of the spending that the United States spends per capita on healthcare for its constituency. And like we mentioned, the U.S. is just off the charts in terms of the amount of money that we spend on each person per year per capita, both in private and in public healthcare spending. Now, we talked about before, the private healthcare expenditure were exceptionally higher than most countries because we require citizens in the United States to have private health insurance. But just because we're spending more money on health coverage and healthcare doesn't necessarily mean we're receiving the best coverage and the best healthcare. Like you said, the United States currently ranks 35 as the in terms of healthiest nations in the world. So it's not necessarily that we're receiving the best medical treatment or the best healthcare in the United States. The reality is that we're just paying more for expenses. And then when we look at public healthcare spending, we're still paying an exceptionally high amount comparatively speaking. And something that's important to note about all of these countries listed here, almost all of them, with the exception of, I think, the United States, I think maybe Denmark and Japan. Other than those, all of these other countries here that are paying a little higher than what's average or typical for public healthcare spending provide some form of universal health coverage for its constituency, which means that their private costs are virtually nothing in comparison to many of these other nations here. So like I said, it's not just that we're paying more in private healthcare spending, we're also paying a lot in public healthcare spending already for things like Medicare and Medicaid. So there's definitely got to be a better solution here. Getting rid of a lot of that private healthcare expenditures that we have in the United States would definitely save billions of dollars and save money overall for all Americans. So let's talk a little bit about some of the implications specifically that COVID-19 is going to have on health and healthcare in the United States. As I previously had stated, COVID-19 is a social problem. I wrote a blog post and recorded a video explaining the sociological implications that COVID-19 is likely going to have and has already had on communities around, not just in the U.S., but around the world. But just, I think, given that this is a week we're talking about disparities, health disparities, it's important to draw some connections to what's currently going on related to COVID-19. It's really important to acknowledge that marginalized communities will be disproportionately impacted by COVID-19. For many of the reasons that we've talked about in the previous mini lecture here, where we talked about the implications of socioeconomic status, race, and gender, right? All of those marginalized communities, poor communities, people of color, and women are likely going to be disproportionately affected by COVID-19. Specifically, marginalized communities have poorer health and are likely more likely to have pre-existing health conditions. Marginalized communities are less likely to have health insurance and therefore will avoid seeking treatment if they become ill. And then also, and I think most importantly, marginalized communities who are struggling to survive financially during this crisis are likely going to be the first individuals who are coerced back into the workforce. And I'm arguing they're going to be coerced back into the workforce prematurely, which obviously would increase their likelihood of contracting COVID-19 and spreading it to their families and their loved ones as well. So one of the pieces I've assigned this week is a short piece that I just recently wrote. I did a little bit of analysis to really try and better understand this rush to reopen the states in the U.S. I know a lot of people are getting stir crazy. A lot of people want to, quote unquote, go back to normal as soon as we possibly can. But the reality of the situation is that we just do not have enough data right now to reopen. We do not have enough tests distributed throughout the United States to really understand how far spread COVID-19 is or how many people are infected by it. Current data suggests that we have barely tested 1% of our population for COVID-19. So that clearly is not enough, and Texas actually has the second lowest testing rate per capita out of all of the states in the U.S. And here we are as one of the states that's really pushing to reopen as soon as possible. So there's a lot of sociological applications to this. Like I said, pushing to reopen sooner than later means that as soon as businesses reopen and people are able to go back to work, we can expect government funding, emergency aid relief, to stop completely. So some of you may have recently received $1,200 stimulus checks because the government created the stimulus package to provide some sort of financial aid to people who are currently out of work. But once we reopen, when states declare that it's okay to reopen, you can expect that those types of stimulus aid, that funding, is going to be depleted. And as a result, people are going to be forced back into work, whether or not they feel safe doing so, whether or not the virus really is contained for right now. They're going to be forced back into the workforce. And almost inevitably, what we can expect is another sharp spike in the number of COVID-19 cases, and we will likely see other epicenters similar to what we saw in New York City surface throughout the United States, because we're simply not ready to reopen yet. We don't have the data that proves that it's safe, and it's going to be marginalized communities, poor working class communities, that are going to be most negatively impacted by this. So I wrote a brief piece, and I've included in the assigned readings this week. I'd love to hear your thoughts on that writing, and there's a discussion question for you in your weekly assignment this week to kind of unpack the sociological implications of COVID-19 on the health and healthcare systems we currently have in the United States. So let's wrap it up by talking about some things that we can do to improve health and healthcare in the U.S. Well, first and foremost, we can definitely do a better job training our healthcare workers about the sociological implications of health, specifically at the intersections of different marginalized communities. So we know that poor people, people of color, and women are likely to receive inferior health care, largely as a result of the stigmas and the prejudice and the biases that healthcare workers have in our society against oppressed groups. So something we can do is strive to pass more laws and encourage and in fact require healthcare workers to routinely complete cultural competency trainings in order to reduce bias and discriminatory practices, right? Similar to the way that this class has hopefully risen the awareness to many of you of biases that we all, as members of living in societies that still are plagued with racism and sexism and classism, have, gaining an awareness of those biases is the first step in this process. So requiring doctors and nurses to take cultural competency trainings to learn more sociology related to health and health disparities can help them address biases that they may have and help them make more informed decisions in healthcare practices. We're starting to see a stronger push for these types of trainings in healthcare workers. In fact, the MCAT, the entrance exam that doctors have to take to get into medical school, now has a series of questions pertaining to the sociology of medicine and sociology of healthcare. So we're starting to see a greater stress on this in the healthcare setting, but there's definitely more that we can do. Something that you can do as students at an interpersonal level is encouraging your friends that are pursuing careers or degrees in the healthcare setting to take more classes in sociology. I always encourage nursing students, pre-med students, I say a great double major for you is to add a major in sociology, because obviously we need healthcare workers that are informed about the sociological implications of health and different structures that prevent certain individuals from seeking adequate health care. We need more sociologically educated healthcare workers in the world. So it's a great double major to major in sociology and nursing, or sociology and biology, or whatever, any other pre-med field, because it really does expose you to the sociological side of health and healthcare, which is very, very important. So if you have any friends, encourage them to take more courses in sociology if they're looking into careers in the medical field. In fact, next spring, I'm hoping to be teaching for the first time in a long time a course on the sociology of health called the sociology of medicine. So stay tuned if that's something you're interested in. I'm, like I said, really hoping to get that on the books in the spring of 2021. From more of a structural perspective, we can also consider how the United States is situated in a global perspective, and recognize the mountains of evidence that adopting a universal health care plan, which is also referred to as a single-payer system or Medicare for all system, would drastically improve the quality of health for all U.S. citizens. I mean, if there's one takeaway we can see, it's that every country that has put into place some form of universal health care, they have greater health outcomes. People in those countries are paying less overall for them, so there's really just no reason that we in the U.S. aren't following suit and learning from the successes of other countries and implementing a universal healthcare system. The main drawback that a lot of people have from universal healthcare systems is that they're afraid that they're going to have to pay more taxes as a result. And yes, it is likely that if we would have a universal healthcare system, the taxes that we would pay for that public healthcare would rise. But when you take into consideration the billions, if not trillions of dollars we would save not paying private insurance premiums every year, we would be paying less out of pocket overall with a Medicare for All system than what we're currently paying, right? In fact, there's mountains of research that supports this. One of the readings that I assigned this week is a summary that found, looking at 22 different studies examining how much we would pay going to a universal healthcare system versus what we're paying in our current system of private health insurance. 22 studies consistently found and agree that we would be paying less out of pocket. As this article that I assigned says, all of the studies, regardless of ideological orientation, showed that long-term cost savings were likely. Even this right-wing think tank that conducted a study found that estimated that about $2 trillion in net savings over 10 years from switching to a single-payer Medicare for All system. Most importantly, everyone in America, everyone would have a high-quality healthcare coverage. Because currently, like we said in the United States, about 10 people are uninsured. Predominantly, those are people that are lower class, especially people living in poverty. So by switching over to a universal healthcare system, not only would we be saving money per capita, but we would also ensure better health outcomes for every citizen, regardless of their socioeconomic status.